Okay, good morning. We're going to continue to move forward with our program and our keynote session for this Friday session. Thank you for your attendance. We are super excited, of course, for this part in our program. And I am pleasured and privileged to introduce our distinguished speaker. This morning we have a distinguished educator, clinician, and investigator as our speaker, an individual who shares the distinction of really shaping current management paradigms for congenital cytomegalovirus management. Dr. Pablo Sanchez is triple boarded in pediatrics, neonatology, and infectious disease. And in some ways, this is a bit of a coming home for him as he began his career here in Dallas as an assistant professor in the Department of Pediatrics at the UT Southwestern Dallas Children's Hospital, where he rose to the rank of full professor with tenure prior to transitioning to the Midwest. He completed his medical school at the College of Medicine at the University of Pittsburgh, residency at the Children's Hospital of Pittsburgh, and fellowships at Columbia Presbyterian in neonatology and UT Southwestern in Dallas in pediatric infectious disease. He is presently a professor of pediatrics at the Ohio State University College of Medicine and employed at Nationwide Children's Hospital. Through his expertise, the Division of Neonatology has grown to become a leading voice, particularly with their involvement in the Neonatal Research Network. Dr. Sanchez's clinical and translational research focuses on perinatal infections and antibiotic stewardship have resulted in multi-decade funding from the NIH, and he is presently a principal investigator and the Center for Perinatal Research at the Abigail Wexner Research Institute. He's been on multiple committees for the CDC, FDA, NIH, et cetera, and has been key in CMV diagnostics, CMV detection, and of course a part of that classic article in 2015 that looks at establishing valganciclovir as a standard of care. Without further ado, Dr. Sanchez, we're happy to have you this morning. Thank you.
Thank you, Cedric. It's really a great pleasure to be here. And first of all, I do want to thank Oliver Adonka and the scientific committee for inviting me. Like Cedric said, it's a great pleasure to be back in Dallas. I was here 25 years, and it's almost like I feel like I came back home. But today, it's great pleasure to speak with you today because you are in the forefront of our struggle, fight, battle with congenital CMV infection. And I was really delighted to hear that what you've been doing on a legislative front, which is very similar to what we're trying to do, as you'll hear today, with congenital CMV, and not only targeted screening, but eventually universal screening. So with that, I don't have any disclosures except that I will speak on unapproved use of ganciclovir and valganciclovir in neonates. And today, I really want to focus on several things. I need to highlight the problem of congenital CMV, not only in the United States, but globally. I need to tell you about how the babies get CMV in the first place, a vertical transmission from mother to fetus. And then the sequelae, which for this audience is really the hearing, but we can't forget about the neurologic as well, and neurodevelopmental. And that has become, the hearing has become the reason that we want to screen newborns, and the reason why we want to actually really screen not just targeted, but universally, and then also to speak about treatment and the treatment options that are available, and then as a pediatrician, I have to speak to you about ultimately prevention of this congenital infection. So it is a huge public health problem worldwide. It's not just in the United States. About 1 out of every 200 babies who are born in the world and in the United States are infected with this virus. That translates to about 40,000 infants who are born infected each year in the United States, and over 8,000 of them will have sequelae or fatal outcome, like you can see on this picture with cerebral palsy, spastic quadriplegia, with mental deficiencies, and certainly hearing loss. So a little bit about this virus. First of all, it's human cytomegalovirus, meaning that we only infect each other. And that's been a problem because we don't have an animal model of human cytomegalovirus. And I think that's really has prevented us from learning a lot about the pathophysiology of hearing loss in these children. It is a DNA virus. It's in the herpes family group, meaning that once we're infected with CMV, we're infected for life. It never goes away. And so it becomes latent, and then periodically it becomes active. And we don't feel any different when it is actively shedding in all our body fluids. It was discovered back in 1881 by Rippert, and actually it was discovered from the salivary gland of a baby who died with congenital syphilis, which has been my second favorite congenital infection, if I may rank them. Actually, syphilis, I think, takes number one. I've worked with that a lot. But actually, it used to be called salivary gland virus because that's where it was first discovered. The infected cells are large, cytomegalic, and that's where has the internuclear and cytoplasmic inclusions, and thereby gives the name cytomegalovirus. Infection with this virus has been seen in every human population. And among childbearing women, about 50% of them have already been infected with CMV, leaving about 50% susceptible to a new infection. But as I'll let you know, it doesn't really matter because we get reinfected with this virus continuously. And the transmission really requires close, intimate contact with infected fluids and secretions. And when the virus is active in us, all our body fluids contain this virus. Urine, oropharyngeal secretions, semen, cervical, vaginal secretions, certainly breast milk, which is a very common mode of transmission. But what's important is that these fluids they contaminate fomites, they contaminate toys and others, as you can see on this slide. All these, one child puts with CMV, whether it was acquired or congenital, gets the saliva on the toy, and the other child, particularly in group settings such as daycare, the other children will become infected. And we know that the source of maternal infection is very much young children, whether they're in daycare or not, but also infected sexual partners. And it is a true congenital infection, and meaning that congenital CMV is acquired by the fetus transplacentally. So the woman is viremic at some point in the pregnancy. It crosses the placenta and infects the fetus. But there's other ways that the baby can become infected. As I mentioned, CMV can be active in her vaginal cervical secretions. And if the baby is born when the mother is shedding CMV in her vaginal cervical secretions, about 50% of those babies will acquire CMV at that time. However, they'll only present with infection around 46 weeks of age, later than the congenital cases, which are present at birth. And also, breastfeeding is really common. So a woman who breastfeeds for 6 to 12 months, as we would like her to do, during that time, and she's CMV positive, she's likely to reactivate CMV during that period of time. And anywhere between 30 to 70% of the babies will become infected with CMV. And because these babies in general are term, they have CMV IgG antibodies, and it's a benign, asymptomatic infection. May not be the case in the premature baby. And there's no question that the babies who I take care of in the NICU, breast milk is the most common mode of transmission postnatally. And about 20% of babies, less than 1,500 grams, who receive either fresh or frozen breast milk from their moms, they will become infected. About 4 to 5% will develop disease, including NEC, including mortality. And so these babies, though, as far as we know, there's been no association with hearing loss, unlike the ones with congenital CMV, but it becomes a problem if we have a targeted screening and these babies get tested at 2 to 3 months right before discharge, they have hearing loss, or they refer on the hearing screen, and then they test positive for CMV, and then we're not sure when they got it unless you have screening at the time of admission. The blood transfusion has been eliminated from at least the NICUs in the United States. See. So again, transplacental infection, and I think it's important to know how often this occurs. So if a mother has CMV for the first time during her pregnancy, about 40% of the time the fetus will become infected. So the placenta does form a barrier in the majority of these cases in which the women acquire primary CMV during the pregnancy. But again, she can reactivate the CMV during the pregnancy, and about 1% of those babies will become infected in utero. But what's become really important is that even the woman who is CMV IgG positive before conception or at conception, some of these women will become reinfected with a different strain of the virus that can lead to congenital infection. And in a study in Brazil, this was apparent in about 18% of the cases of congenital syphilis, congenital CMV that they had seen in their center. And so that is the problem with current serologic screening of pregnant women, because whether she is CMV positive or CMV IgG negative, the same precautions need to be taken, and she needs to try to prevent any exposure to other people's body fluids. And among all of these babies who are infected with CMV, the 1 out of every 200 babies born in the United States, 90% of them are so-called asymptomatic. And I put it in quotes because when you read the studies and you need to see how that was defined. So in general, these are babies who are term, who look well, appear well, and their physical exam is normal. We have shown that if you do further evaluation of those babies by CBC, platelets, head ultrasound, eye exams, about 40% of those so-called asymptomatic babies are not so asymptomatic, and we find clinical manifestation, laboratory or radiologic manifestations. 10% of them, though, are born with clinical signs, and those are the ones who are called symptomatic, like in this child with the blueberry muffin spots, the thrombocytopenia, and the jaundice. And other clinical manifestations you can see here, they're in the minority of babies. Hepatosplenomegaly is a very, very common petechiae, small for gestational age. It's rare to have pneumonitis, cerebral calcifications, as you can see there. And we've been screening our NICU on admission, all the babies for CMV, and we've actually noted that we have a case series of about 9 babies who had pulmonary hypertension at birth and had congenital CMV. And so when I speak with these parents, they want to know what's the future. And, as you know, none of us can predict the future. But the two things that really are on their minds and on our minds is the neurodevelopmental outcomes. And it certainly is a big issue. And among these babies, the neurodevelopmental outcome is really predicated on neuroimaging. And the head ultrasound, which is an excellent screen, you can see some of the periventricular calcifications. Some of these babies will have dilated ventricles. But the biggest concern with neurodevelopmental outcome in these infants is when CMV infects the fetus early in gestation, because it can cause what we call neuronal migrational disorders. So when CMV infects the developing brain, it can cause the neurons, the brain cells, not to go to the appropriate place. And there you have the cortical dysplasia, so the abnormal brain formation, abnormal gyral pattern. And 70% of those babies, if you see that abnormality on MRI, 70% of those babies in our studies and others, we will have moderate to severe disabilities as determined by Bailey examination at 2 to 3 years of age. I would love to do MRI on all of my babies, but right now I'm screening with head ultrasound, followed by MRI. And actually what is pertinent to your group is when they get the MRI, I then have them do the cochlear views, because that will eliminate further MRI and sedation, and later on, if that child were to develop profound deafness later and is a candidate for cochlear implantation, you can just take care of those 2 studies in the neonatal period when you don't have to sedate them. So the other one, of course, and pertinent to this group here, is the sensory neural hearing loss. And among those so-called symptomatic infants, about 48% of them will have hearing loss. And 30% of these will have delayed onset, meaning that their newborn screen, their diagnostic ABRs in the first month of age is normal, but then they develop hearing loss later in life. Among those so-called asymptomatic, about 7% will have hearing loss. But importantly, very importantly, 18%, in addition, 18% of them will have delayed onset sensory neural hearing loss that's detected from 25 to 62 months with a median of 27 months. And this was nicely pointed out by Karen Fowler, who's an epidemiologist, very much involved in hearing studies with congenital CMV from Alabama, where she studied 307 children with asymptomatic congenital CMV infection. 7% had sensory neural hearing loss at the initial exam. 50% had further deterioration in hearing from 2 to 70 months of age. And really, and we know that congenital CMV is associated with progressive hearing loss. But those babies will identify in the newborn screen because they already have hearing loss at birth. But 18% of them will have that delayed onset. And yes, it's more common in the first 2 to 3 years of age, but it can be as late as 6 years of age. And I tell these parents that even through adolescence, and who knows, even in adulthood, we just haven't been identifying a lot of these babies with congenital CMV. And we've had two children who had normal hearing up to 6 years of age, and at the 6-year study, they had profound sensory neural hearing loss unilaterally, and both of them had congenital CMV. And then the fluctuating hearing loss at about 23% of these infants. So how do we make the diagnosis? So it's actually quite easy. You can certainly isolate or detect the virus by either culture or by PCR. And PCR is more sensitive, and we recommend currently that CMV PCR be done in the urine. The urine is the diagnostic source, but saliva is excellent for screening. And as we propose universal screening, what we actually are proposing is that saliva PCR be done on all newborns. What I want to leave with this group is that do not do CMV IgM. It is a horrible test. Don't waste your time, don't waste your energy. There's not only false negatives, but there's false positives. So don't do that. But what is really important is that we need to get the detection of CMV in the first 3 weeks of age. Because after 3 weeks, we don't know if that baby acquired CMV as he was born through a birth canal that was shedding CMV, or if it was acquired through breast milk, or if it was acquired through contact with other children, or through other caregivers. And this has brought up why not the dry blood spot for newborn screening. And Minneapolis, they did this study in Minnesota, and you'll hear it later, that Minnesota is the first state as of January to have universal CMV screening and testing of the dry blood spot. They found a sensitivity of 86%, and to me, that's not high enough, because if you have a screening test, it should be 100% or close to it. However, we'll see what the results are. If the dry blood spot CMV PCR were 100% sensitive, I can tell you that we would be screening every single baby in the United States for congenital CMV. And not just in the United States, it would be globally. But the sensitivity has just not been there. In our hands, in our lab, at Nationwide Children's, our sensitivity has been about 65%. And so we're left with saliva testing and screening, which is what we are currently doing in all of the NICUs in Columbus. But our recommendation is to do urine CMV if you strongly suspect it, but if you're unable to get the urine, do the saliva in these babies who you are concerned could have CMV. And the saliva in the CHIME study, which is a multi-center study that we participated here while I was in Dallas, it was in Alabama, Suresh Babana, the sensitivity was 99 to 100%. But we really are focused now on more targeted screening, and hearing and referral on the newborn hearing screen is only one of several targeted interventions. Any child, any neonate, any newborn who has any clinical, laboratory, or radiographic signs of possible CMV infection should be tested for CMV. And this is whether they have isolated thrombocytopenia, petechiae. You know, it's not because the mother had preeclampsia, and the baby is not small just because the mother had hypertension during the pregnancy. It could be CMV, and we need to test it. And also the other one is that babies who are born to HIV-positive mothers. And we and others have documented transmission rates as high as 3 to 7% of babies born to mothers who are HIV positive will have congenital CMV, much greater than the 0.5%. So all these babies born to mothers who are HIV, we are testing them for CMV in the newborn period. And then, of course, and pertinent to this audience, is those who do not pass the hearing screen. And I just want to really point out this study that we did. So in 1998, when I was in Dallas here, the state mandated universal newborn hearing screen. And talking to my friends in the newborn nursery at Parkland Hospital, here, the county hospital, I was like, we should find out why these babies are referring on the newborn hearing screen. Why can't they hear? And I said, we should, you know, we are physicians, we're healthcare professionals, we should be inquisitive. And so maybe it's CMV. So Kaylee Steele, who's a pediatrician at Parkland, she was a pediatric medical student, resident, and with us in Dallas, and a good friend, along with Angela Shoup, who many of you know. Was the head of audiology here, and also Chris Owens, an audiologist, superb group of people. So we decided that every baby born at Parkland who referred on the newborn hearing screen would be tested for CMV. And we found that 6% of those babies had congenital CMV. And importantly, 75% of those babies were only tested because they had referred on the newborn hearing screen. Yet, when we evaluated them, many of them should have been tested because some of them were microcephalic. You did a head ultrasound, and they had periventricular calcifications and other signs that would be consistent with congenital CMV. However, we need to realize, because of the congenital CMV, the hearing loss can occur late, that newborn hearing screening only identified 57% of CMV-related hearing loss in another universal screening study, the CHIME study that was done by Karen Fowler. So we definitely are missing some, although we are at least identifying and trying to find the cause for the hearing loss in these neonates. How about, as you know, we can't do hearing testing in babies who are less than 34 weeks gestational age. So maybe we should be doing universal testing on all of these babies. And how about all NICU admissions? So we looked at when does the first hearing screen, when is it done in a level 4 NICU, referral NICU at Nationwide Children's Hospital? It's a large NICU of 128 beds. And we noticed that 36% of these infants in the NICU had their first hearing screen performed at greater than 21 days of age. At a time when, if the CMV is positive, we don't know where that baby acquired, especially we want universal provision of breast milk to all of our premature and high-risk babies. But what was really interesting is that 11% of them were term. So they had other conditions that precluded doing an early hearing. So this was a missed opportunity for diagnosis and institution of antiviral therapy. And so we instituted universal CMV testing and screening of all admissions to the NICU in the 9 NICUs in Columbus. And what we found was that universal screening increased the identification of congenital CMV in the NICU by 45%, 38% of these infants had abnormal evaluation, and then in some cases prompted antiviral therapy. Caution, though, because we had 15% false positive CMV screens, not just with saliva, but also with urine. This is a PCR test. We've learned from COVID, if nothing else, that there are some false positive PCRs. And now I am requiring 2 positive PCRs, of which one of them is urine, in order to confirm and tell these families that they definitely have that their baby has congenital CMV. And I just want to give a shout out to Oliver Prashant Malhotra, who's the head of our hearing disorders, Ursula, and Gina, and my nurse Tracy, who keeps me in line, and certainly I need that many times. But we have a great group that is focused on congenital CMV. And our hearing evaluation, we do the hearing screen at birth, but if we identify congenital CMV in any of these babies, we do a diagnostic ABR to confirm the normal hearing. And then we do repeat it at 3 months, 8 to 10 months, and then every 6 months through 6 years of age. And why is that? Because we really want to determine whether these babies are eligible for treatment. And this was the first study that ever provided ganciclovir, an antiviral agent, to neonates. And in this study that we were part of both in Columbus as well as here in Dallas, but it was led by David Kimberlin, who's a pediatric ID person in Alabama. These babies had all had central nervous system infection with CMV. The microcephaly, abnormal neuroimaging, and/or hearing loss. The problem with this study that although we enrolled 100, only 47 of them, 50% of them were lost to follow-up. The primary outcome was hearing. But it definitely showed benefit. When you compared IV ganciclovir to no therapy, the improved hearing or remain normal was 85% in the treated group versus 56% in the no treatment group. But none of the treated group had worse hearing. And when we looked at it at a year of age or so, also, there was less hearing deterioration. And really, these antiviral therapy, once they have profound sensory neural hearing loss, it's not going to reverse it. But what we want to do with the antiviral therapy is to prevent the hearing deterioration so that they can, at least through 2 years of age. So it really lets all of that brain formation and all these auditory connections that are occurring in these babies and these infants to really take hold and establish some hearing before they may ultimately need cochlear implantation if they develop a profound sensory neural hearing loss. And luckily, there was an oral version of ganciclovir, oral valganciclovir. The dose is 16 per kilo every 12 hours, given orally twice a day, every 12 hours. It is improved. The absorption is improved with feeding, so I tell the parents to provide some feeding, breast milk or formula afterwards. And so this was a multi-center study, also headed by David Kimberlin. We were part of it in Dallas, enrolled 109 infants with symptomatic congenital CMV. About 2/3 of them had central nervous system disease, but that was not a requirement. And the primary outcome was hearing at 6 months. And what you can see on this slide in the green is that comparing 6 weeks versus 6 months of oral valganciclovir, in the green, where it's improved or remained normal, there was not statistically significant difference at 6 months of age. That was the primary outcome. But when we look at the secondary outcomes that were defined a priori, there was significant improvement or the hearing remained normal from birth to 12 months of age if the child had received 6 months of treatment. Then when we looked at it from birth to 24 months, it remained significant but less so. I think there is no question treatment is not a universal panacea. However, it has a moderate effect on improving hearing outcomes. And not surprisingly, when we look at the Bailey scales, the 6-month group had improved language, composite, and receptor communication scales. But if you look at the actual scores in the motor, fine motor, gross motor, and cognitive, although it was not statistically significant because they were empowered for those outcomes, the scores actually were better with the 6-month group. We have little evidence to state to parents that treatment will improve neurodevelopmental outcome, and I am upfront with that. However, some studies suggest that there is a benefit, and I will tell you that anecdotally, after taking care of these babies since the late 1980s, I think that their outcomes by treatment has improved. And so and all of these studies enroll babies in the first month of age. How about treatment beyond the month of age? So in this study, also by the group in Alabama, if they had hearing loss secondary to congenital CMV from greater than a month of age and less than 4 years of age, these children received 6 weeks of valganciclovir versus placebo. And unfortunately, it did not show any benefit. Valganciclovir decreased CMV in saliva and urine, but there was no measurable clinical effect on patient outcomes. And valganciclovir therapy, however, was well tolerated in this population. There's no question that there is some mild neutropenia and sometimes even severe where it is less than 500. It is reversible, and we do stop. And then it comes back. I do tell these families And ganciclovir in high doses given to laboratory animals is a carcinogen, it's a teratogen, and it's been associated with gonadal dysgenesis. And all of the parents who I speak with, all my patients' parents, I tell them that up front. None of that has been seen in humans. And we certainly have given a lot of ganciclovir and valganciclovir to the human population, not just to neonates. And so I'm very comfortable with the administration of this drug to these infants. Oops, sorry. I just wanted to just state that we are currently doing transcriptome analysis of babies with congenital CMV to try to determine which of these babies will develop late onset hearing loss. And with Asun Mejias, who is a pediatric ID, a colleague of mine at Nationwide, who is now at St. Jude, we actually, by doing microarray analysis, we identified a 16-gene classifier signature associated with sensory neural hearing loss with a 92% accuracy among asymptomatic infants. And we're extending this study nationally to see whether we can identify these neonates with respect to development of hearing loss, because that really is the crux of the problem, since we are not doing universal screening. But I just want to leave you also to say that we've looked at our cohort of almost 300 infants and children with congenital CMV, and we looked to see whether these babies got treated with ganciclovir or valganciclovir or not. And unfortunately, late onset sensory neural hearing loss occurred among 10% of the treated children and 7% of the untreated. So we need better strategies. Was 6 months too short? Should they be put on suppression? Should we be following viral loads? There's still a lot to be learned about the treatment of congenital CMV. So in conclusion, is it time to screen? Universal, I can tell you that 20 years ago I said no, 10 years ago I said maybe, and right now I think every newborn should know whether they have congenital CMV. Selective screening, definitely, no question. Is it time to treat? Yes. Clinically apparent, symptomatic, but no documented central nervous system disease? Yes. In the first month of age and for 6 months of therapy. But we are not treating that newborn, that neonate, who is completely asymptomatic. And by asymptomatic is the congenital CMV baby whose evaluation is completely normal. Not just the baby who has normal growth parameters and normal growth parameters and normal physical exam. So prevention, ACOG does not recommend universal screening, and I think what we really need to push for in these pregnant women and pregnant is education. We need to make them aware. 90% of parents whose children have congenital CMV are not even aware that CMV even exists. And so it is really important to at least educate them and tell them how CMV is transmitted within the household. But I'm still not an advocate, because as I said to you, whether she's CMV IgG positive or CMV IgG negative, she's still at risk of acquiring it, either a new infection or reinfection, and certainly reactivation, which we cannot do anything about. But then, we don't exclude children from daycare. Standard precautions is the key. But I really want to leave you on a hopeful note, because Moderna is currently studying a messenger RNA CMV vaccine in women 16 to 40 years of age. And that is the future, is vaccination. And so when you look at the CDC website, you can see what the recommendations are to pregnant women who, in order to try to prevent being infected with CMV during the pregnancy, and it's quite complex. And what we really need is a vaccine, and hopefully the Moderna messenger RNA vaccine will work. So with that, thank you. It's time to act. It's time to screen. And I'm glad to ask any questions if you like. I just want to leave you that we will be hosting at Nationwide Children's in Columbus the 9th International Congenital CMV meeting next year in June, and you're all welcome to join us. Thank you.
Dr. Sanchez, we want to say thank you again for that very informative, helpful message this morning on behalf of all the constituents and the families that they represent. I believe at this time we have concluded this session with our time, but I know he will be around, of course, to answer questions for you for the remainder of this morning. Thank you very much.